And breast cancer is diagnosed every 29 seconds around the world. And in the United States, it's about every 2 minutes. So really, it impacts so many people across the world. Just some high-yield statistics. So breast cancer is the most common cancer in women, excluding skin cancers, which are usually excised. And in 2020, an estimated close to like 275,000 new cases of invasive breast cancer are expected to be diagnosed in women in the United States, along with about close to 50,000 new cases of sort of a non-invasive or pre-breast cancer. About 2,600 new cases of invasive breast cancer are expected to be diagnosed in men. So it's clearly a lot lower of an impact. As I said before, 1 in 8 women will be diagnosed with breast cancer in their life, but 1 in 883 men, which is usually associated with genetic risks for men to develop breast cancer. About 42,000 women are expected to die in 2020 from breast cancer. And the death rates have been steady in women under 50 since 2007 and have continued to drop in women over 50. So part of that is because it tends to be a more aggressive disease in the younger population. It's often diagnosed not via screening, but via someone who has symptoms. So it can be a little bit more advanced at diagnosis in the younger population. The overall death rate from breast cancer has decreased by about 1.5% from 2013 to 2017. And these decreases are thought to be due to treatment advances and also early detection. And so the idea is that more than 3.5 million women have a history of breast cancer in the United States. So it's pretty staggering. So now, kind of shifting gears a little bit, I'm going to focus a lot of the talk on what our screening guidelines are and what you guys can be doing to sort of help prevent breast cancer. So in terms of generating screening guidelines, when we develop these guidelines and all these different organizations create guidelines for women or men for different testing, the idea is to really balance the benefits and the harms of these tests, right? So in terms of benefit, what is the probability that doing this test, you're going to detect something that would have been fatal before, and you're finding it before the onset of symptoms? And what's the probability that finding it early leads to better health outcomes, right? So the idea is less death, less, morbidity from it, as opposed to, well, if I just found it once it already had symptoms, will it change anything? In terms of the harm, when we're looking at tests, we want to make sure that, what's the probability that this test might find a finding that needs further workup, so that you maybe get a biopsy, but it doesn't actually show cancer, so you're causing more harm to the person getting tested. And what's the probability that those harms associated with detecting will basically diagnose cancer, but that maybe that cancer would never have been treated otherwise? So if you have a 90-year-old woman who's diagnosed with an early breast cancer that maybe never would have impacted their mortality, so you're sort of giving them an extra diagnosis that maybe we don't really need. So that's kind of the background for developing these guidelines. And we use different organizations that I'll sort of touch base a little and explain to you a little bit in terms of what we use. From my standpoint, the American Cancer Society is sort of what we use as our guidelines. And so if we're looking at an average risk woman, so somebody who doesn't have any personal or family history of breast cancer, they don't have any genes that are known to increase the risk of breast cancer, they've never had radiation, and they've never had any prior findings. So in those women, so kind of that category, the main age that we really recommend starting screening is at age 45. Per the American Cancer Society, so women between the ages of 40 and 44, they have the option to discuss with their doctor and to come up with a decision if they want to start screening earlier. So the ages between 45 and 54, you should get yearly mammograms, and then above 55, they recommend either yearly or every other year. Again, this is sort of a discussion with your provider, and the screening should continue basically as long as you're in good health and expected to live for at least 10 more years. So just kind of to show you how these guidelines can vary. So I just spoke to, in terms of this category, the American Cancer Society, but really we have many different organizations that will give guidelines basically between the ages of 40, and 45 is where there's that gray area, and whether or not you're supposed to get a mammogram every year or every other year is sort of, again, where that the varies a little bit. The U.S. PTSF, which is the United Preventive Services Task Force, that really guides internal medicine doctors, so primary care doctors that are going to order a lot of your mammograms. They actually don't recommend screening until the age of 50. And their guidelines are from between age 50 to 74, and to screen every 2 years. So sort of this category here. And again, you can make a decision with your healthcare provider if you want to screen between 40 and 49. There's been data that this really, misses a lot of cancer that would have otherwise been diagnosed. About a third of cancer will be missed by only screening during these, 25 years or 24 years. And again, with the every other year, and it can lead to, potentially missing close to 10,000 deaths per year. So while, I may have potentially initially trained in an internal medicine setting, the oncology guidelines are to do it yearly, and again, to at least start at age 45. The National Comprehensive Cancer Network, which is NCCN, and the American College of Radiology, which guides the radiologists and people doing the mammograms, recommend every year starting at age 40 and for as long as a woman is in good health. So as you see, there's definitely different guidelines and a little bit of a gray area, but definitely starting at age 50, but really probably a little bit earlier, you should be getting yearly to every other year mammograms. So what is a mammogram? I'm sure many of you have had mammograms before, but basically it's low dose x-rays of the breast. And the idea is that regular mammograms can help find a breast cancer at an early stage. So, as we had mentioned before, when we develop these guidelines, right, we want to be able to find something that we can treat earlier and have less morbidity and mortality later on. So by having regular mammograms, you're more likely to find early stage breast cancer, need less aggressive treatment. So, the idea is that you won't need to have your whole breast removed, a mastectomy, but you can just cut out the area of the surgery. Less likely to need chemotherapy if a cancer is diagnosed, and more likely to actually be cured of the cancer. But with the caveat that mammograms are not a perfect test. They can occasionally miss some cancers, and sometimes we'll have unclear findings where you'll need additional tests to see something that we are not sure of on a mammogram. So just for those who haven't had mammograms before, so in a mammogram, kind of as this image depicts, each breast is compressed horizontally. So you have these two plates that flatten the breast tissue. It's definitely not a comfortable procedure, but hopefully every year, other year is not too bad. And in a standard 2D mammogram, you typically take 2 pictures of each breast. So, this is sort of the idea in a very, basic form of a cartoon, what a normal mammogram would look like, where we don't really see, anything that looks abnormal. You have your normal, the ducts that, for getting milk, and the lobules, which I'll discuss later with you, cancer where there's clearly this irregular finding here. There might be something that's what we call well circumcised, so, very regular margins, and it just looks like a cyst and not really anything cancerous, and calcifications, which sometimes can lead to irregularities later on. So more recently, there's been the development of 3D mammograms. So I'm sure many of you have heard of this before, where the idea is instead of taking just those 2 pictures of each breast, we're taking significantly more pictures and getting a more thorough view of what the breasts look like. It's becoming more common, but it's still not widely available in all breast imaging centers. So, it's potentially not something that where you would go for your mammogram, they would have it. But it does, studies have suggested that there seems to be a lower chance of, being called back for follow-up testing. So that first test is more accurate in determining really, is this something that should we be concerned about or not? It tends to find more cancers. If you have more dense breasts, it's potentially more helpful, but it's not a guarantee that it's more helpful, and less false positives. So the idea is less that you're going to end up needing a biopsy for something that ends up being non-cancerous or benign. Unfortunately, these mammograms do cost more, and it's not always covered by insurance. A lot of centers that have these 3D mammograms available will eat up the cost. So even though the insurance might not cover it, they feel that it's worth it for them to have this available, and they'll offer it to patients, and they won't charge you that extra cost out of pocket. We're hoping that with new codes from an insurance standpoint, that soon these will be covered more universally by insurance. And one other thing to note with 3D mammograms is because it's providing extra imaging, there is a risk of having increased radiation exposure. It's still under the limit of what FDA would recommend for these kind of screening tests, so it's not something that we would be concerned is going to cause future cancers down the line. And newer programs being developed will hopefully start to limit this extra radiation exposure as well. So just kind of from an image standpoint, in terms of the idea of what is the difference really between a 2D mammogram and a 3D. So as I had shown you before with the plates, in the 2D mammogram, you're really just taking a view from the top and the side of each breast, right? And those can show the regular breast tissue in a flat image. If 3D, you're taking multiple different x-rays kind of all around the breast, and that can create this 3D view at one slice at a time and hopefully better differentiate whether something is concerning or not. So this is the first image here is a 2D image. And as you can see, like even if there was something there, you can't really tell, is this something concerning or not, right? You'd have to look really thoroughly and you make something up basically. Versus in a 3D, you're more likely in a small slice to be able to detect that. I was, listening and heard an analogy that I thought was pretty interesting or helpful to kind of help understand the difference, is that a 2D mammogram is looking like at a book, right? You're looking at the cover and the back, and really you're not able to see anything in between. Well, a 3D mammogram, you're really looking at all of the pages. So in a 2D mammogram, you're only getting 4 images, right? 2 of each breast, while in a 3D mammogram, you're getting about 200 images. So it's significantly more. And these are each 1 millimeter slices. So, thin slices of the breast, and you can get a better depiction of what is actually going on and hopefully, knowing whether this is something concerning or not. So in terms of, there was, a large study relatively recently just published in July in one of our big journals comparing 3D and 2D mammograms. And basically what it showed is that if you get 3D imaging, it tends to decrease the rate of getting called back for a mammogram by about 10%. So, in 107 out of 1,000 exams to 91 out of 1,000. So, for a woman who might have a lot of anxiety by having to go back for a repeat image, that 10% can be pretty significant. And it also tends to detect about 41% more invasive cancers. So that's, again, a pretty significant number. The one caveat or thing to kind of be aware of, and not to make you kind of understand what these charts say, but basically what this is looking at is, this is somebody who's getting their first time mammogram versus a second mammogram, right? For their second, they're being called back. So when the lines here are very wide, that means that there's a lot of variability between the 3D and the 2D, and the more narrow shows that there's not much variability. So basically, in the first time you're getting the mammogram, the 3D seems to show that there is less likely to get recalled and more cancers to be detected, but it seems to not really have any significance or implication the second time. So it's really just more helpful in that initial testing. Also, the one thing that this study sort of mentioned, and when I had spoken about before, that it might be a helpful test in women with dense breasts, they did not seem to show any benefit in somebody who has extremely dense breasts, that this test didn't seem to do anything different than a 2D mammogram. In somebody who has what's called heterogeneously dense, so meaning that there's scattered areas of density within the breast, then it seemed to actually be helpful. So just something to kind of be aware of, that we have these 2 different imaging modalities, this 2D mammogram versus a 3D mammogram to help diagnose and, breast cancer. So then the question is, what about any other tests? Do you need to do anything besides a mammogram to detect breast cancer? So as this kind of, headline shows, follow-up mammogram with an ultrasound, which some women will be sent for, might detect more cancers. But the additional tests often can give more false positives, meaning you'll often need to get more biopsies unnecessarily that really don't actually show any cancer. So as I said, a breast ultrasound, it's used to follow up on an abnormal screening mammogram. So really, we don't do it as a routine screening, but only if something is detected that we then want to evaluate further. Often we use the ultrasound to guide a biopsy as well. It can on occasion detect these early stage cancers that we don't see on a mammogram, especially if you have very dense breasts. It can often pick up the nuances that we don't see on a mammogram. As I had mentioned before, there is this increase in false positives. So on occasion, you will have to have more of a biopsy for something that is actually nothing. And it hasn't shown to decrease mortality. So meaning just because you're seeing something on ultrasound, your lifespan is not going to be affected by having this. So it's not something that we routinely recommend. So just some helpful stats, kind of reiterating a little bit of what we said. So if you think about 1,000 women who are having a screening mammogram, 100 out of those 1,000 will so about 10% will end up having to come back for either another mammogram or an ultrasound to kind of differentiate something that was seen on that first mammogram. 61 of those people will end up having additional imaging that really doesn't show anything. So, in that 10%, really, 60% of those will not really have any problems, and it's just an extra test for nothing. 20 of them will find that basically, what was seen on imaging is probably not cancer. We use a screening on something called BI-RADS for mammogram. So it'll be something called a BI-RADS 3, where it's most likely benign. But the mammographer, the radiologist will probably recommend following it up in 6 months as opposed to a year or 2 years, just to confirm that there's no changes on what was seen. 19 out of that 1,000 will end up having a biopsy. And 5 out of those 1,000, so 5 out of those 19 who had biopsies will end up being diagnosed with breast cancer. So while it's still not a very high percentage, it's clearly a very important test to help us diagnose those cancers early and hopefully lead to a very high cure rate for breast cancer. So, I had mentioned that those guidelines from the American Cancer Society were initially for those at average risk. So what about for people who are considered high risk? So what is high risk? Those would be people who have a lifetime risk of breast cancer of about 20 to 25% or greater, according to risk assessment tools, which I'll show you sort of how we use those. And it's usually based a lot on family history. So if somebody has a known BRCA1 or BRCA2 mutation, which, is more common in the Ashkenazi Jewish population, you've probably heard some of it from, Angelina Jolie effect, or people, have these mutations and they might decide to have their breast removed. If somebody has a first degree relative, so if they have a parent, a brother, sister, child with these mutations, and they haven't actually been tested themselves, so we still consider them at high risk. If you've had radiation to your chest between the ages of 10 and 30, so that's typically, if we think of it in somebody maybe who had Hodgkin's disease when they were a child or a young adult, they're at increased risk of having breast cancer. And then if you have any of these different genetic syndromes or first degree relative with one of those, again, you're in this high risk category. So in people in that category, there's actually a recommendation to get an MRI in addition to a mammogram. And the age of screening goes down significantly from either that 50 or 40 to age 30. So really, you're screening these people at a much, much higher, earlier stage and a little bit more aggressively, because we know that they're just at that much higher probability. So basically, if I told you before that the average woman has a 12.5 chance of getting breast cancer, these are 25%. So it's basically double the risk. So we need to be a little bit more cautious in our screening. The caveat here is MRI shouldn't be done without mammograms, because on occasion the MRI will miss something that the mammogram detected. So we usually recommend doing both of them for screening. And then there's sort of these women that they're not really high risk enough, but we know that they're at increased risk than a normal or baseline population. And those are people who have previously had breast cancer. If you've had any of these sort of pre-invasive breast cancers, which I'll discuss a little bit later, but these what we call in situ, so it's not actual breast cancer, but earlier stage, or any atypical findings on prior biopsies, or if you have, as I had mentioned, these very, very dense breasts, those times screening mammogram might be recommended. There is not enough data to say that it should be definitely done on a yearly basis, but definitely something to consider in that population. So as I had mentioned, there's something called a breast cancer risk assessment tool. where we basically can combine all a woman's different risks to determine, if different treatment needs to be done or different testing needs to be done in women. So there's something called this Gale risk model, and I'll kind of go through this, and I'm going to try to pull it up for you and to show you what it is that we use. But it includes age. So the older you are, the higher your risk of developing the breast cancer. If you've had any family history, if you've had prior breast biopsies that had abnormal findings. Breast cancer, one of the main risks, and again, I'll discuss this a little later, in breast cancer, of developing breast cancer, is if you've had a long amount of estrogen exposure. So if you were really young when you had your first period, then you're more likely to have had a longer period of having estrogen exposure and potentially then have a slightly increased risk of breast cancer. Again, if you were older when you had your first child, then again, you're having that longer period of having estrogen that being exposed to. So your risk is a little bit higher, and in first degree relatives as well with breast cancer. So essentially what the model does is it calculates a percentage of risk within 5 years and over one's lifetime when compared to a woman of average risk. So if your 5-year risk is actually more than 1.7%, you might be a candidate for preventative medicine that we often will give to decrease your risk of breast cancer. And these are hormone type medicines that when you would see an oncologist or someone who would provide that medicine for you, and we typically will weigh the risks and benefits of the medicine versus potentially decreasing your risk of breast cancer. So I'm going to try to do here. I hope you can still see this. Let's see what I'll do here. Okay, so I'm hoping you can see this screen. But this is from the National Cancer Institute, but it's this, what I was saying, this breast cancer risk assessment tool. And it sort of goes through how we can do it. And you click on here to assess the risk. So this tool is only used if you've never had, if you don't have a mutation. So if you don't have the BRCA1 or BRCA2, because there we already know you're at increased risk. So you have to click no there. And, do you have any medical history of having these pre-invasive diseases? And again, or radiation. So we're excluding that really high risk category before you can even use this tool to just, determine your average risk. So we're saying no. And then, as I had mentioned here, you can put in different things. And again, this is arbitrary, but here, I'm going to, let's see that. And again, have you ever had a biopsy? So if you said yes to that, and how many have you had? And maybe you've had some atypical findings on the biopsy. You were 10 years old when you had your first period. You were 25 when you had your first pregnancy. And if you've had any family, first degree. So we're saying that none. And you just click here and you calculate your risk, and it just creates a nice little model showing you what your risk is versus an average risk. Again, that's for 5 years, and then it also shows a lifetime. And using that, we can sort of just determine what the ideal protocol is for screening and for also potentially treatment. So going back to the slides here. Okay. So I know that in the flyer we had spoken a little there, it had mentioned that we'll talk about clinical breast exams. So just with the caveat here, the American Cancer Society does not recommend routine self-breast exams or clinical breast exams in someone of average risk. And part of the reason is that a lot of the findings you would find are really probably nothing, and it can often lead to increased anxiety, increased testing for no reason, or it can potentially miss things if you think you're just doing that and not doing standard mammograms. But I'll go through a little bit of how it's done if you choose to do it. So as I had mentioned, a clear benefit of doing these exams, whether as clinical, which is by a doctor, or by the women themselves, is not really clear. There is pretty little evidence that these tests will help find breast cancer early when women also get a screening mammogram. So the mammograms are usually a lot more high yield in detecting breast cancer. Typically, or most often, when a woman does detect a lump or something abnormal, usually it's doing normal activities. If they're taking a shower, you're getting dressed, you might feel something. So doing an organized or a set time to do a breast exam is not necessarily needed. The main thing to really take away here is that women should be familiar with how their breasts normally look and feel, and to report any changes to any kind of healthcare provider right away. So if you do feel something abnormal, we want to make sure that you're following up appropriately. And some women, you might actually feel more comfortable doing regular self-breast exams to keep track again of how your breasts look and feel. But just kind of with the caveat that knowing that doing these routinely, there's little evidence that it can help for these women at average risk. So in terms of the steps, I included these pictures to kind of just give you an idea of what is a proper self-breast exam if you were to do it. So the first step is really standing up. You want to look at yourself in the mirror. Your shoulders are straight, your arms are on your hips, to kind of just get a feel for what your breasts look like, their usual shape, their size, their color, because every woman has different breasts, and sort of knowing your own breasts is what's important for you. You want to see that they're evenly shaped. A lot of people don't have exactly the same size at each breast, but just knowing what they look like and what their shape is. No, significant distortion or swelling. But if when doing that, you see significant puckering, bulging of the skin in a certain area, or, dimpling so that the skin goes in at a certain area that was not there before. If your nipple has changed position, or it actually goes in now, instead of sticking out, or there's increased redness, soreness, those are things that you want to talk to your doctor about. The next step would be to lift your arms up, and then looking for the same kind of changes that we had mentioned above. And then also, while you're in the mirror, looking for any signs that anything's coming out of the nipple. So is there any discharge? Obviously, if you're breastfeeding, that's a completely different thing, but this is in somebody who's often postmenopausal, but they might have, milk or different kind of discharge coming out. That's usually a concerning sign and symptom. The next step would be that you would lie down, and you take your hand, typically your right hand to feel your left breast and your left hand to feel your right breast. And you want to kind of use a firm touch using the finger pads on your hand, keeping them flat together and kind of either in a circular motion or kind of an up and down motion, to kind of cover the entire area of the breast. So you can go all the way around the breast in all different sides, just to make sure that you're covering the whole breast when you're doing it. And then the last step would be to do the same kind of motion of using your fingers and going around your breast, but either in the sitting or standing position. A lot of women can do this in the shower, and you're sort of doing the whole thing. And I do really want to emphasize, though, that doing a regular self-breast exam is really not needed. But if you sort of are in this higher risk category, it's then something that we might recommend more. So just kind of summarizing what the normal kind of self-breast exam, typically if you are going to do it, it's around once a month, and it can be done after your period. It should usually be done at a similar time of your period, because often people, especially if you're younger, there's a condition called fibrocystic breasts, that as you have your period and you're menstruating, you might develop little cysts that will then resolve. So you just want to make sure that you're looking at a similar time when the hormones are expressed certain. And again, looking at the breast and the armpit, using your finger pads. And as I had mentioned, you can either do this up and down motion, or kind of going in these wedges or circles, and looking at your breasts again in the mirror to looking for different sort of changes that we might observe. So shifting gears a little bit from our screening, touch base a little bit in terms of what are the abnormalities that we might see and what the normal breast versus abnormal breast findings are. So as most of people kind of know, so you have the normal breast here, you have your nipple, and the areola is the surrounding area, the hyperpigmented or the darkened area around the nipple. And then there is a whole chain of lymph nodes that kind of will go in a certain direction that drain from the breast. And then there's, all behind the breast, there's the muscle and the ribs. And within the breast, there's a lot of fatty tissue. And then there are these ducts and the lobes. So those are the areas that, again, will create milk. And when people are breastfeeding, those are the areas that we focus on. And that's the ducts and lobes are where we see the cancer develop. So again, kind of looking at this in the sense of these are your glands and your ducts and your lobes. So a normal duct, you have surrounding your membrane and normal cells there. In something called ductal carcinoma in situ, which is a stage 0 or pre-invasive disease, you have these abnormal cancer cells that will be within the duct, but they don't go outside of the duct. So they're still well contained, so that it's not something concerning enough that it's going to be leaving and being cancer. Versus an invasive cancer, they're actually leaving the duct themselves and causing more concerning findings. So, when somebody gets a breast biopsy, what are the concerning things then that we're really looking for, right? The concerning finding that's the least, I would say, concerning, but still something abnormal, is something called atypical ductal or lobular hyperplasia. Those are two different conditions. Where basically, if you look at this kind of image here, right, again, we have our duct and lobe. As I had mentioned before, here's your normal, right, no abnormal cells. Hyperplasia is when there's just increased growth of different cells, right? So these are normal cells that are growing. When those cells look slightly abnormal, that's when we call them atypical. Usually, there's not enough of any atypia there to be concerned that this would be a cancer or a precancerous lesion. But in a woman like that, again, those might be somebody who you're going to spur to image more frequently, just to make sure that they're not then going to develop breast cancer. There's no reason to cut anything out there. There's no role for surgery there. It just requires either closer monitoring, and on a rare occasion, we can consider medicines, again, just kind of suppress your hormones to prevent any cancer from developing. Then there's these, what we call in situ or pre-invasive diseases. Ductal carcinoma in situ is a stage 0 breast cancer. And again, it's when there's sort of cancerous cells, but they're not outside of the duct. That does require treatment. Typically in somebody who has this, and you may have heard of the acronym, or it's DCIS. If you have that condition, we often will treat somebody with surgery, either removing the entire breast, or if you remove part of the breast and just the abnormal part, then we would often follow that with radiation. And if that area expresses estrogen, we might then give you pills to then prevent any new breast cancer from coming out. But again, it's a stage 0, and once you cut it out, we don't expect that actually that breast cancer will come back. Lobular carcinoma in situ is when there is these, again, abnormal cells in the lobe and not actually in the duct. That is no longer considered a stage 0. It's not something that we would do surgery for. It's similar more to these first category, where we're just going to monitor those women with more frequent imaging, and occasionally, again, you can consider these pills to help with hormones. And then the last thing that you would see is it's our breast cancer, right? So then it's when, as I mentioned before, the cells sort of leave the surrounding duct and can kind of infiltrate to the surrounding breast tissue. And those can either sometimes express estrogen, sometimes they don't. And they can also express a marker, a receptor called HER2, which often, if it does express that, we can use specific targeted agents to give. And I'm not going to go into that extensively for you guys. So now that we kind of have an understanding of what our screening guidelines are and what potential abnormalities are, I just wanted to briefly touch on some risk factors and what maybe we can do to help prevent the development of breast cancer in the first place. So going back to our high risk, right? So there's some unavoidable risk factors, right? So if you're older age, you're just going to be a higher risk. So as you get older, I treat many women who are in their 90s. And so just as you get older, you just have a higher chance of having cells abnormally replicate and cause cancer. Genetics, so we know, again, if you have certain gene abnormalities, that puts you at increased risk for breast cancer. Race, if you are African American, you're at an increased risk of developing breast cancer. As I mentioned before, radiation and at a certain age point can increase your risk. If you have very dense breasts or these benign conditions, again, you're put in a slightly higher risk, personal family history. And as we had seen with testing, or the kind of your looking at your risk, those having when you had your period, your reproductive history, so that increased estrogen exposure can automatically put you at a higher risk for breast cancer. So what about modifiable risks? Like what can you do to sort of prevent the development of breast cancer? So I'm going to go through some of these individually, but these ideas here is birth control, regular exercise, hormone therapies, smoking, diet, exercise, alcohol. So those are different things that we potentially can adjust and avoid to decrease your risk of developing a breast cancer. So people might ask about, if you're taking birth control, does that increase your risk? So there's not so much data to suggest that if you're on birth control that you're really going to have much of an increased risk. And we do know that taking hormone birth control does actually decrease your risk of uterine cancer and ovarian cancer. So if you're taking it, we don't ever tell you to stop it because of developing breast cancer, because of a risk of breast cancer. However, if you do develop breast cancer, we will often have you then stop it, because going forward, we don't want you to be suppressing those hormones further, or giving yourself hormones, further. And what about if you're postmenopausal? A lot of women who, have hot flashes or other symptoms, vaginal dryness, you might be taking hormones. So is there data to suggest that those hormone replacements can increase your risk? And it definitely does slightly increase your risk of breast cancer. So every year that you use those, your risk of breast cancer can increase by a little over 2%. The idea is so typically when we're saying hormone replacement, it's a lot of times estrogen with progesterone. If you're using an estrogen alone type agent, which is what we call unopposed estrogen, that may be more okay and have a lower risk of causing breast cancer. The risk of using hormone replacement tends to increase if you're using it for a very extended period of time. So let's say you had just a few months of this medicine, it doesn't tend to increase your risk too much. But if you were on it for 10 plus years, there's a higher risk. So basically, the main point to take across is if you need these for symptom control, right? If you have significant hot flashes, you have significant dryness, other things, the recommendation would be to take this unopposed estrogen, and again, for the shortest amount of time as possible. So what about alcohol? So again, here, there's somewhat conflicting data, but the idea is that alcohol in and of itself can increase the level of estrogen in the body. And so by drinking a significant amount of alcohol, and when we say significant amount, it tends to be more than 3 drinks a week, 3 glasses or, hard liquor. The idea is it's increasing your risk of estrogen positive breast cancer. So there are two, as I had mentioned, there are different types of breast cancer. So it doesn't increase your risk of all types of breast cancer, but that unopposed estrogen, those type of breast cancers will be seen. And there's also the idea it sometimes can damage the DNA in cells, too much alcohol. So that might be one other mechanism of increasing the risk of breast cancer. And so as you see all these different headlines, that, their regular drinking boosts that risk, half a glass of wine increases your risk. So really the takeaway is if you're going to drink alcohol, drinking in moderation. 1 drink a week seems to be totally fine. It doesn't really significantly increase that risk. But having, a drink every night, while it might have that heart, the cardioprotective area, because we know that red wine does, help with the heart, it might slightly increase your risk of breast cancer. And kind of what I had to mention, those every 3 drinks a week, and every drink on top of that can increase your risk by about 10%. So definitely drinking in moderation is key. What about obesity and being overweight? There is some data to say that women, if you're overweight or obese after menopause, so the biggest thing is this data does not apply to women who are young. Like if you're in your 40s and you're overweight, that's okay, or from a breast cancer standpoint. But if it's after menopause, you might have a 30 to 60% higher chance of getting breast cancer. On the other hand, basically what I'm saying is if you're overweight or obese before menopause, you actually might have a lower chance of breast cancer. So there's a little bit of give and take here. But from an overall health standpoint, the older you are, you want to try to eat a healthier diet and kind of limit how, because fat tissue itself can lead to increased estrogen, which can then lead to development of breast cancer. So this nice image here sort of emphasizes or reiterates a little bit of what we were saying, where these idea of the fat cell, right, your adipose cells, they can, after menopause, the estrogen that's made by the fat cells can increase faster in the breasts, and then increase your risk of developing cancer in both the, your uterus and in your breasts. There's also the idea that excess fat can lead to levels of insulin and other growth factors to increase, which then leads to cells dividing more rapidly and a higher chance of having abnormal cells develop. And then just being overweight in general, there's just an increased state of inflammation. And there are these chemicals released called cytokines that can, again, encourage cells to divide. These are just different ideas. There's not tons of definitive evidence, but I think enough to suggest that, decreasing the amount of fat you have, or at least intake in the diet, can potentially decrease your risk of developing breast cancer. So then you might ask, like, what are the recommended diets that one would then want to be on in these situations? So there is not great data to say one diet over another. The Mediterranean diet, which emphasizes fruits, vegetables, whole grains, decreased red meat, processed food, alcohol, is often what we recommend. I would say that in a standard risk woman, the diet itself is not something that's going to have huge implications. Typically, if you've already had abnormal findings, so you have that pre-invasive breast cancer, or you've already had breast cancer, then in those cases, we have a lot more data to suggest that diets, rich in fruit and vegetables, low in red meat, have implications going forward with decreasing your chance of having a recurrence of your breast cancer or developing another breast cancer. So from that, I kind of open up to any questions for you guys. And I can also sort of leave it at this slide.